Good afternoon, dear students. Today we will discuss very interesting topic. Concerning Broncho Obstructive syndrome or syndrome of airflow limitation. And also we discuss topic about respiratory failure. So start with definition. Let's start with definition. Broncho obstructive syndrome or airflow limitation syndrome, a set of clinical manifestation resulting from generalized narrowing of the bronchi associated with airflow limitation of different etiology. In this slide, you can see the main diseases which lead to syndrome of obstructive lung disease, airflow limitation syndrome, including such diseases as asthma, chronic obstructive pulmonary diseases, bronchiectasis, bronchiolitis, obstructive sleep apnea, gastroesophageal reflux, lung cancer, eosinophilic granulomatosis with polyangiitis, past name Charles-Stross syndrome, epiglottitis, subglottic stenosis, and foreign body. Patient with bronchoobstructive syndrome often complains of chest tightness, of inability to get a deep breath. Whereas patients with congestive heart disease more commonly report a hunger of sense of suffocation. Tempo of onset and duration of patient dyspnea. You should put before you some question. Is it acute process or chronic process, or maybe exacerbation of chronic process? Acute shortness of breath is usually associated with sudden physiological changes such as laryngeal edema, bronchospasm, myocardial infarction, pulmonary embolism, or pneumothorax. It's new clinical signs. Before it had no registered such symptom like, for example, dyspnea in case of such acute process. Patient with COPD have got experience of gradual progression of dyspnea on exertion, punctuated by acute exacerbation of shortness of breath. Sometimes when we meet with patient with COPD first time during exacerbation of COPD, patient complains like a acute process, but usually because it's not passive process of summarize complaints of patient, you should active ask patient about it was dyspnea of shortness of breath due to physical exertion before this accident, before this period. Often patients say yes, but it's not significant sometimes. That's why you should make conclusion about it's not acute process, it's chronic process. But this chronic process is exacerbated under the influence of several factors, including viruses and some kinds of exposure, exacerbation of comorbidity, and sometimes acute process. For example, patient with COPD can have pneumonia as the acute infection of the bronchi exacerbates this chronic process. But that's why you should pay attention about comorbidity. Most asthmatic have normal breathing in majority of the time, with recurrent episode of dyspnea that are usually associated with specific triggers, such as the upper respiratory tract infection, lower respiratory tract infection, or exposure to allergens. Acute cough, but you should note that acute cough, this cough duration less than 3 weeks, Between 3 weeks up to 8 weeks, it's subacute cough. Productive of phlegm is often symptom of infection of the respiratory system, including process affecting the upper airways, including tracheitis, laryngitis, sinusitis, and lower airways, including bronchitis, pneumonia. Both the quality and quantity of the sputum, including whether it's blood stickers or frankly bloody, should be determined. That's why you should ask the patient about the color of the sputum and volume of the sputum. It's because infection process accompanied by mucopurulent and purulent sputum. Mucopurulent and mostly green color, pardon, yellow color in case of purulent in green color of the sputum. It's accompanied by bacterial infection. In case of virus infection, it may be colorless or mucus type of the sputum. Chronic cough, defined as a persistent more than 8 weeks, is commonly associated with obstructive lung disease, particularly asthma, and chronic bronchitis, as well as non-respiratory disease such as gastroesophageal reflux and postnasal drip. I would like to tell about, just once more, about asthma. Asthma is heterogeneous disease, usually characterized by chronic airflow inflammation. In the center of the definition of bronchial asthma is our understanding this is a chronic inflammatory process in airways, localized at airways. Yeah, but so you can ask me that chronic bronchitis also is chronic airways inflammation. It's true. By the way, you what about I have a few words about criteria of chronic bronchitis? It's, chronic cough, duration more than 3 months during 2 consecutive years. That's why each yes patient have got a cough during at least 3 months. But chronic cough never, chronic bronchitis never lead to variable expiratory airflow limitation. variable expiratory airflow limitation. But bronchial asthma, chronic inflammation in case of bronchial asthma, lead to variable expiratory airflow limitation, which manifestate with respiratory systems such as wheezing, shortness of breath, and chest tightness, and cough. That vary over time and intensity. We discuss about what morphological changes provide this variable respiratory airflow limitation. We will say it about later. But COPD, you can see the definition of global initiatives for obstructive lung disease from 2015, and now we have such different definition, and comparing this definition, chronic COPD is a common preventable and treatable disease characterized by persistent airflow limitation. Persistent airflow limitation is crucial for both definition, but in case of previous, it was enhanced chronic inflammatory responses in the airways. But now we recognize COPD as the process with persistent airflow limitation and respiratory symptoms persistent. This is due to airways and alveolar abnormalities, usually caused by significant exposure of noxious particles and gases. That's why it's a difference. Now, the definition of chronic inflammatory response of airways and the lungs was excluded and changed for alveolar and airway abnormalities. But now we, frankly speaking, airways inflammation typically for both diseases, bronchial asthma and COPD, present. But I thought that we explain what morphological change provide variable airflow limitation in case of bronchial asthma. In this slide, you can see that very significant hypertrophy of smooth muscles layer happen preferably in case of asthma, practically absent in case of COPD. By the way, smooth muscles cells can be find its submucous layer in a patient with bronchial asthma. It's not typical localization of submucous cells. It's that's why in case of bronchial asthma we have got so-called remodeling of the bronchus. That's a very hypertrophy of smooth muscles provide variable airflow limitation and very significant constriction, narrowing of the bronchi under influence specific, sometimes unspecific stimulus, like allergen, like dust mite, and other provoke factor. That's very important things. But in case of bronchial asthma, we have hypertrophy of basal membrane of epithelial. In case of COPD, frankly speaking, basal membrane significantly diminish from the normal size of this basal membrane of normal bronchus. It's not only theoretical interest to know about it. But I know such clinical cases when we discuss with pathomorphologists. Yeah. For our opinion, patient death was due to pulmonary edema. But for opinion of pathomorphologists, patient died due to COPD. But under the reporting, after reporting of morphological changes, we pay attention that patient had got a enlarged of basal membrane. We explain these changes in pulmonary edema, but pathomorphologists can't to explain why, in case of COPD, in the increase of basal membrane. It's not typically. That's why we gain victory in discussion with pathomorphologists due to Lектor conference. But other things more typically for patients with COPD, and explain why in case of COPD we have got a persistent airflow limitation. It's so-called peribronchial fibrosis. Peribronchial fibrosis, these morphological changes provide persistent airflow limitation because this peribronchial fibrosis surrounded bronchi, like a ring, limit the bronchial dilation of narrowing of the bronchi. That's why if very important abnormalities in the bronchi which support persistent airflow limitations. That's why I come back to this definition. It's due to airway abnormalities. This abnormalities is peribronchial fibrosis. Fibrosis surrounded the bronchi. And last pathological change in lung parenchyma happen in case, preferable in case in patient with COPD. It's formation of emphysema. Emphysema, it's also lead to persistent airflow limitation in case of COPD because excessive residual volume in the gap alveolar after during exhalation compress a small size of bronchi and support this persistent airflow limitation. That's why it's abnormalities of the lung parenchyma support persistent airflow limitations. That's why it's more exactly defined, and this last definition, which information from the definition of COPD was excluded, but include airways or parenchyma abnormalities which support persistent airflow limitation. By the way, in case of bronchial asthma, we can manage this information using inhaled corticosteroids, firstly, because all inhaled corticosteroids play an active role in all kinds of information in case of bronchial asthma. Comparing bronchial asthma in case of COPD, unfortunately, we can tools we can't tools for good manage of information on COPD. But why? We will say an answer for this question later. In this slide, you can see what difference for in case of bronchial asthma and COPD concerning the trigger factor. In case of bronchial asthma, it's mostly allergen. In case of COPD, it's hazard noxious particles or gases. First of all, it's cigarette smoking. And what type of inflammatory cells play an active role in case of inflammation in COPD? In bronchial asthma, it's mast cells, eosinophils, CD4 cells, it's T helper cells. But now a new scientific investigation confirmed not only CD4 lymphocytes play in this information. By the way, previously it's called Th2 information. Now, this information, in case of bronchial asthma, in case of allergy, it's called T2 information, because CD4 cells, as you know, it's cells for adaptive immune response. But you should know that in case of inflammation in patient with bronchial asthma, the cells which belong to innate immunity also play an active role for formation this T2 information. These cells called like lymphoid cells type 2 and the dendritic cells type 2. That's this information now called T2 information. But it may be higher T2 in case of first type of hyperresponsiveness, which play active role IgE immunoglobulins, antibodies belong to these IgE immunoglobulins, and lower T2. In case of, for example, fourth type, mostly allergic inflammation, when mostly cells play an active roles in T2 inflammation. But now we have very important molecular tools for manage this information in the severe case of bronchial asthma. In the case of severe duration, we can use of monoclonal antibody against, for example, IgE immunoglobulins or specific cytokines which produce all type of cells which formate T2 information in case of bronchial asthma. Comparing with patient with COPD, main inflammatory cells is neutrophils and cytotoxic cells, CD8 plus cells, which often lead to inflammation, cellular inflammation, like Th1 inflammation, which producing such cytokines like tumor necrosis factor alpha, IL-8, IL-1 beta, IL-6, lead to persistent inflammation. By the way, unfortunately, we can't manage for neutrophil inflammation because if you block neutrophils, because previously it was a several attempt to block neutrophils, but unfortunately, block neutrophils as a very important cells of innate immunity lead to high risk of bacterial complication, high risk of sepsis and others. That's why these clinical trials which propose monoclonal antibody against adhesion molecules of neutrophils failed due to increased mortality patient with COPD after complication, bacterial complication after sepsis with development of acute respiratory distress syndrome or polyorganic failure and others. That's why in case of COPD, we can't manage this information comparing with patient with bronchial asthma. But it's not means we should not treat. We can treat. We can make prophylaxis of COPD. We should treat this patient correctly. But unfortunately, this treatment is only not directly have not direct impact for information in case of COPD. So if we are talking about onset, asthma onset, it may be in childhood, and COPD, which diagnoses more than a patient with more than 40 years of old. And previously history for patient with asthma, it's allergy. In case of COPD, it's mostly chronic bronchitis. Pattern of respiratory system in case of asthma, symptoms vary over the time, day to day, over a longer period. Often limiting activity, triggered by exercise, emotion, including water, dust, exposure of allergens. And in case of COPD, and symptoms persistent. Those are main symptoms: cough and dyspnea, persistent each days, but not. I never say all day long, but each day present. But it may be better days, good days, worse days. Patient has about some influence of several factors, but present each days. Lung function in case of COPD between episode of exacerbation, it's not not changed. But in case of bronchial asthma, you can detect positive, in most of cases, positive reversibility test, and in medical tests you can find hyperresponsibilities of bronchi. In the case of COPD, the main spirography criteria of COPD, it's post-bronchial dilated test, FEV1 to forced vital capacity, less than 0.7 or 70%. It's crucial. Post-bronchial test should be ratio between FEV1 and FEVC should be less than 0.7. Without this criteria, you can't make diagnosis for COPD. I talked about lung function between exacerbation, normal in case of asthma, and persistent airflow limitation in case of COPD. Past history in case of asthma, including previous diagnosis of asthma, family history of allergy and asthma. In the case of COPD, it's a heavy exposure to risk factor of tobacco smoking, and or inhalation of professional hazard, including biomass fuel and other. And previous diagnosis of COPD or chronic bronchitis or emphysema. Time course of asthma, no worsening of symptoms over time. Symptoms vary either seasonally or from years to years, may improve spontaneously, or have an immediate response to bronchodilators. Or if patient who have use of inhaled corticosteroids, it's maybe over weeks after start of this therapy. But in case of COPD, symptoms slowly worsen over time, progressive course over years. And rapid-acting bronchodilators treatment provide only a limited relief because by the way, it's not absent of response. Sometimes patients have with COPD have got a positive reversibility test, approximately 25%. That's why you can't make diagnosis COPD only for spirometry investigation. You should summarize all clinical, instrumental data and response to treatment. It's very important things. For example, in patient with diagnosis for COPD after start of treatment, for example, diminish of forced expiratory volume for 1 second, normalize. It's not COPD. You should change diagnosis for bronchial asthma. Other things, if you make diagnosis bronchial asthma and the patient have no answer for our therapy, it's patient have got a slowly worsening of symptoms of airflow limitation. You also should change diagnosis for COPD. Chest X-ray in case of asthma is normal, but in case of COPD, you can see severe hyperinflation and emphysema, air trapping, especially in case of higher resolution computer tomography. Sometimes you can find patients who have got both symptoms, asthma and COPD. It's previously it's called asthma COPD overlap symptom, but now this term changed for combination asthma and COPD. That's why each patient have got asthma and COPD. If patient have got more than 3 symptoms for asthma and more than or equal symptoms of COPD. And last changes in case of so-called GINA. You should know GINA, it's guidelines for management and treatment of bronchial asthma. And now our relation to so-called mild asthma significantly changed. Previously, it was our desirable level of stage of treatment to convert severe asthma for mild asthma. But now, you can see such clinical results. 30% of adults with have diagnosis with mild asthma have got acute asthma exacerbation. Among these, 60% patients have got a near-fatal asthma. 50% of acute exacerbation died from the asthma who have got a diagnosis mild asthma. That's why mild asthma, it's not mild. It's because patients pay less attention for treatment, for support asthma control, and sometimes mild asthma have got an acute complication. This acute complication often severe, near fatal asthma complication, and some patient death. That's why it's a very important, since sometimes it's explained patient stop use control medication. Patient not treat, for example, allergy status like sensibilization to dust mite, to pollen, and for example, and during pollen season, it's lead to severe, sometimes fatal bronchial asthma exacerbation. So also changes in the GINA. It's concerning inhaled short-acting beta agonist. Inhaled SABA, it has been first-line treatment for the asthma for 40 years. But now the conclusion of the top quality specialists in the world that regular frequent use of SABA is associated with adverse effect. Firstly, it's a beta receptor down regulation, decreased bronchial protection, rebound hyperresponsiveness of bronchi, and a decrease of bronchodilators response, and increased allergic response, and increase eosinophilic airway inflammation. And patients who use more than 3 canisters of salbutamol, for example, per year, associated with high risk of admission to emergency department and high risk of death. That's why you should, in each visit of patient with bronchial asthma, you should ask patient about using of short-acting beta agonist or as a emergency situation. So previously, recommendation concerning using SABA for step 1. Previously, it's recommendation was that in case of step 1, for example, asthma with very rare exacerbation, patient can use only SABA as a monotherapy. Now it's prohibited. GINA now recommended that all adults and adolescents with asthma should receive inhaled corticosteroids containing controlled treatment to reduce the risk of serious effect. And now SABA monotherapy, other words, is prohibited for treatment bronchial asthma. For example, for initial therapy, for example, patient who have symptoms twice a month or more, for example, or less, less than twice a month. Very rare, very rare. If patient have symptoms less than twice a month and less, can be used as needed for low dosage inhaled corticosteroids and formoterol. But now it's more investigated combination budesonide with inhaled corticosteroids. For example, Symbicort. In case of exacerbation, patient should and can use these drugs as a reliever medication. But in the case of this situation, patient obtained not only short-acting beta agonist, but long-acting beta agonism. Formoterol, it's long-acting beta agonist, but very quickly onset of action. But it's lead to long-term bronchial dilation because formoterol duration of action approximately 20 hours. But patient with rare exacerbation obtained some doses inhaled corticosteroids which suppress inflammation because, frankly speaking, exacerbation it's uncontrolled inflammation. But patient, because chronic inflammation in the central, I repeat once more, is the central of our understanding what happened with patient with bronchial asthma. It's chronic airflow inflammation. That's why patients should use anti-inflammatory drugs. The more powerful and more effective inflammatory drug is inhaled corticosteroids. That's why patients with very rare exacerbation now first line as needed low dose inhaled corticosteroids or plus formoterol. If patient have twice a month more, in this case, patient have got a daily inhaled corticosteroids and for as a control medication, and use inhaled corticosteroid plus formoterol as a reliever medication. Or in this case, if patient obtained regular inhaled corticosteroids, patient can use SABA as a reliever medication. It's, by the way, the last guidelines updated 2020. It's this step 1 and step 2 combined in each step. And symptoms most days, but not daily. For example, patient can use low dosage inhaled corticosteroids in combination with long-acting beta agonists. So, and but for as a control medication, as a reliever medication, patient can use combination inhaled corticosteroids with formoterol. And symptoms most days, practically each day, it's step 4 medium dosage inhaled corticosteroids plus LABA. And if it's for initial therapy, it's first step, it's first contact with patient. That's why the mostly severity of the bronchial asthma can be evaluated to according to symptoms. You should ask the patient how much per day patient have got the exacerbation of these symptoms or during night. That's why according to these symptoms, you make a conclusion about severity of bronchial asthma and prescribe initial controller treatment. In this slide, you can see that each visit, you should analyze the response for our therapy, and make conclusion about escalation of de-escalation of our controller medication. By the way, but we should reach the plateau of controller symptoms. By the way, after first visit, and then the second and next visit, the severity of bronchial asthma can be evaluated according step of treatment. I repeat once more, according to first visit, you evaluate severity of bronchial asthma according to the symptoms. Second and other step, other visit, you should evaluate severity of bronchial asthma according to step of treatment. For example, patient have no symptoms. During last months, you should analyze at least during last 4 weeks. No symptoms, but patient use high dosage of inhaled corticosteroids plus LABA plus LAMA, long-acting anticholinergic drug. But it's 5 steps. It's severe bronchial asthma. Nevertheless, the patient have no symptoms. But what about symptoms? Symptoms, we should use the symptoms for evaluation of the asthma control. That's why first visit, the symptoms can help you to evaluate the asthma severity. In the second and other next visit, symptoms help you to evaluate asthma control. That's why patients have no symptoms, but higher dosage of corticosteroids plus LAMA plus LABA, it's severe bronchial asthma, but no symptoms. For example, daytime asthma symptoms more than twice a week, no. 0 point. Any night awakening due to asthma, no. A liver needed for serious symptom more than twice a week, no. Any activity limitation, no. That's why we can make conclusion that patients have got a severe bronchial asthma, severe course, but severe controller course. We reach this controller course, asthma control, using of this five step of treatment. But what should we do after when we reach the asthma control? We should wait and sitting of this plateau at least 3 months, because stable condition during 3 months, it's indication for change our treatment. For example, if patient remain on this controller condition, well-controlled condition, no of these symptoms, during 3 months, we can step down from the 5th step to 4th step. Reduce dosage in corticosteroids, because high dosage in corticosteroids, it's high risk of, for example, pneumonia, high risk of changes of so-called microbiome of the respiratory tracts, increase, for example, detection of pneumococcus in the from the in sputum. That's why first step is diminish of inhaled corticosteroids for medium dosage. Inhaled corticosteroids plus LABA, maybe plus LABA. Okay. So it's the same. If patient, for example, patient who have a step 2, it's a mild bronchial asthma. For example, there's small dosage inhaled corticosteroids, but patient have daytime asthma symptom more than twice a week, yes, and relieve medication more than twice a week, it's 2 point. It's, you make conclusion that patient have got a mild bronchial asthma, partial control. But what should you do if we check partial control? We should escalate control of medication, and we should step up from step 2 to step 3. Step 3 is for treatment mostly moderate course of bronchial asthma. For treatment paradigm of this step 3, low dosage inhaled corticosteroids plus LABA. It's a main first choice of treatment for step 3. That's why you should make step up. If a patient during step 3, I recheck the condition of patient after 4 weeks and more, and patient remains controlled, you should remain of this step 3. But if patient no control, what should you do? Firstly, you should evaluate their compliance with patient, adherence to the treatment, and how patient use these inhalation devices for inhalation, correct and incorrect. Patient should bring all devices for inhalation, all drugs, medication during the next visit. And you should say patient to demonstrate, to show how patient use the devices, because incorrectly technique of inhalation lead to ineffectiveness of our therapies. That's why each visit, after first visit, patient should bring all medication and show you how patient can use these devices. This is very important, very crucial. And in this slide, you can see in corticosteroids, low, medium, and high dosage. It's more preferable. It's modern corticosteroids, mometasone, fluticasone, but budesonide, beclomethasone, it's a very long term of using these drugs for treatment a patient with bronchial asthma. And we bet these drugs, all these drugs have great impact for treatment of bronchial asthma and help you to reach control in more than 80% of patients and more. But we told that not only level of control, it's very important since for prevention of poor asthma outcomes. But there are unmodified factor of risk factor for fatality of asthma, for poor asthma outcomes, including every patient was intubated during severe bronchial exacerbation of asthma. Uncontrolled asthma symptoms too, but it's modified. Having more and equal exacerbation at last 20 months. Low forced expiratory volume. It's also modifier factor for the risk factor of poor outcomes. Incorrect inhaler techniques and poor adherence patient for treatment. Also it's modified factor. Smoking, obesity, it's also modifying risk factor. Pregnancy, blood eosinophilia, and by the way, allergy. We should can treat allergy, for example, if patient have such allergic rhinitis, but patient can have a good control most days of the years, but during pollen season, it's lead to bronchial asthma exacerbation, sometimes severe bronchial asthma exacerbation. For prevention of such cases, we should treat allergic rhinitis, treat from the patient with allergen-specific immunotherapy. So, risk factor for fixed airflow limitation, including no treatment with inhaled corticosteroids. By the way, it's specific forms when we during severe intrabronchial inflammation of airways, it's linked to unresponsiveness of the bronchus due to the SABA of LAMA. That's why inhaled corticosteroids restore to sensitivity of beta receptor for this beta agonist, for example, anticholinergic drugs, smoking, occupational exposure, mucus hypersecretion, and blunt eosinophilia, also risk factor for fixed airflow limitation. Risk factor for medication side effects, including frequent using of oral corticosteroids and higher dosage of inhaled corticosteroids, and in combination with inhibitor of cytochrome P415 S2. But what happened? What should we do if we will not reach control using 5 steps of treatment? It's including, I repeat once more, high dosage inhaled corticosteroids, plus long-acting beta agonism, plus long-acting cholinergic drug, inhaled corticosteroid, ICS, plus LAMA, plus LABA. Previously, all these patients were treated by oral corticosteroids, which significant side effect. Now we have got other direction of treatment. Its direction of treatment including to establish of clinical phenotype of bronchial asthma. Its clinical phenotypes, I repeat once more, it's a high T2 inflammation, lower T2 inflammation. In case of high T2 inflammation, we confirm about IgE level of the presence of sensibilization due to using skin prick test or detection of specific IgE, immunoglobulin E, in the serum. It's a confirmation of first type of information. In this type of T2, higher T2 information, it's eosinophil levels, it more or greater or equal 250 cells in 1 microliter. Also, if we can equivalent for the detection of the concentration of an oxide in exhalation air, it's more or greater than 20, and allergen-driven symptoms, childhood of asthma, we can, in this situation, we can prescribe omalizumab. It's monoclonal antibody which blocked IgE receptor, and we patient obtained monthly subcutaneous injection of this monoclonal antibody for reach control of bronchial asthma. Other things, if patient have other type of information, for example, no symptoms for higher T2 information, and patient but patient have got more than 500 cells for eosinophils, in the blood, patient can be eligible to anti-interleukin 5, anti-interleukin 5 receptor treatment. It's, for example, it's these drugs including such medication like mepolizumab or dupilumab, mepolizumab, sreslizumab. This monoclonal antibody blocked interleukins 5. If patient have gotten less eosinophils, but no significant symptoms which confirming about hyperresponsiveness type 1, patient can be eligible to treatment of specific monoclonal antibody to interleukins 4 receptor. It's drugs is called dupilumab. But that's why biological therapy now it's new paradigm for treatment severe uncontrolled asthma, and help you to reach the good control, mostly in case most patients with bronchial asthma. Now, patient who with bronchial asthma which use oral corticosteroids as regular manner, it's practically exclusion than rules, because all these drugs help you to reach the good control. But so if we met with such cases, bronchial that we suspect bronchial asthma, we should treat it as asthma. If we have got, for example, crossing asthma and COPD symptoms, we should also treat such situation as the asthma. But I would like to stress such patient, if you suspect asthma or maybe asthma plus COPD, we should not give beta agonist LABA on LAMA without inhaled corticosteroids. We obviously should give patient inhaled corticosteroids. But if we suspect COPD, we should not treat patient with inhaled corticosteroids as a monotherapy. We will say about it later. But what about montelukast? Montelukast, it's anti-leukotrienes drugs, and now FDA made conclusions that significant side effect of montelukast is including suicidity in adults and adolescents, and behavior problems in children. That's why if you prescribe these drugs, you should know about these adverse events in FDA box warning in March 2020 about risk of serious neuropsychiatric events for using these drugs. So, few words about GOLD strategy report. I would like to stress that diagnosis COPD based on the three categories: first, symptoms, risk factor, and spirometry. Symptoms including dyspnea, shortness of breath, chronic cough, and sputum. Risk factor: exposure of tobacco smoking, post factor, and occupational hazard, and indoor outdoor pollution. And such patient with risk factor plus chronic symptoms should be direct to spirometry investigation. But dyspnea for COPD progressive over time. Have got characteristic worse with exercise, and dyspnea persistent. Like a chronic cough may be intermittent and may be unproductive. Sometimes recurrent wheezing, chronic sputum production. Any pattern of chronic sputum production may indicate COPD. History of risk factor. I talked about smoking, other inhalation of other hazard particles or gases. Family history and other chronic cough, including asthma, lung cancer, tuberculosis, bronchiectasis, left heart failure, interstitial lung disease, cystic fibrosis, and idiopathic cough. That's what you should exclude this factor when we make diagnosis of COPD. And also we should pay attention for extra thoracic causes of chronic cough, including chronic allergic rhinitis, postnasal drip syndrome, upper airway cough syndrome, gastroesophageal reflux, and using of medication. For example, IC inhibitors, approximately 20% patients who use C inhibitor have got experience to this side effect like a cough. So in this slide, you can see the to the left part of the slide, you can see the normal trace in spirograph investigation and patient with COPD. Yeah, I would like to stress that main spirometry criteria is the ratio between forced expiratory volume for 1 second, FEV1, 2, forced vital capacity, FVC, less than 0.7. In this case, you can see this ratio 0.56. For this 0.8, it's normal range. Here, it's obstruction, diminish of, because ratio, it's distribution, obstructive disorder to restrictive disorder. In case of COPD, more significant obstructive disorder under the restrictive disorder. By the way, in case of interstitial lung disease, we talked about it. It's preferable restrictive disorders. This ratio increased, but in case of COPD, this ratio decreased. But we should not, please should not pay great attention for the grade of diminish. This parameter is categorical criteria, plus or minus. Diminish less than 0.7 or above 0.7. For our attention, not pay great attention for the degree of diminish this parameter. It's not important for us. Only the present or absent this criteria. But we should pay attention to the grade of diminish of forced vital, pardon, forced expiratory volume for 1 second. But patients should have this, all patients diminish of force ratio FEV1 FVC less than 0.7. That's why we can evaluate the severity of diminished forced expiratory volume. By the way, after 2007, we should analyze ratio and FEV1 after bronchodilators test only after. For example, if we have got for example this ratio before inhalation of salbutamol, after of inhalation of salbutamol, we can see such ratio. It's not COPD. But COPD, after bronchodilators test, this ratio should be less than 0.7. That's why after bronchodilators test, we analyze and evaluate the grade of diminish of forced expiratory volume for 1 second. If greater or equal 80% from predictable level, it's mild. Mild degree of effort limitation. If forced expiratory volume less or equal or more or equal 50%, but less than 80% from the predictable level, it's moderate degree. If FEV1 greater or equal 30% or less than 50% from the predictable level, it's severe. And gold 4, it's very severe. In case of forced expiratory volume for 1 second, less than 30% from predictable level. It's a very important thing you should know about it. By the way, we told that this FEV1, it's in patient with diminished FEV1 ratio, FEV1 to FVC, it's reflected to bronchial airflow limitation, bronchial obstruction. It's true. But also we know that in case of COPD, it's persistent airflow limitation. That's why if patient have got a severe bronchial asthma limitation from 30% FEVC, we should not wait. We will not wait that after the influence of our therapy, that FEV1 increased more than 50% of predictable level. It's not possible, because it's persistent airflow limitation, but it's not target for our treatment. For all patients with COPD, we should use modified MRC dyspnea scale. There are 3 scales of dyspnea, and by the patient who have got a less than 2, it's not significant dyspnea. More than 2 is significant dyspnea. For example, what does it mean to I walk slower than people of the same age on the level because breathlessness, or I have to stop for breath when walking on my own place on the level. That's very important scales. MMRC scale we will say about these scales in several times, and also COPD assessment test. And for example, a question, for example, I never cough. It's 0 question. If I cough all the time, 5 points. That's why patient checks these scales. If, for example, total score less than 10 points, it means less symptoms. If patient more than 10 points took according COPD assessment test, CAT test, it's patient have more symptoms and more influence for the disease, for the health condition of the patient. And my classification for all patients should be this criteria: post-bronchial dilators test ratio FEV1 or FVC less than 0.7, and we analyze and post-bronchial dilators FEV1 and GOLD 1, 2, 3, 4, and but this it's not our influence of our therapy, but in the central part you can see exacerbation history. It's all patients with COPD can be divided in 2 categories: patient with frequent exacerbation and patient with rare exacerbation. Exacerbation in case of COPD, it's a factor of risk of premature death and reduce of lifespan, such this patient. And we can we can influence for this exacerbation. That's why it's a very important thing. Patients who have one exacerbation leading to hospital admission or two home exacerbation, it's patient with frequent exacerbation. And patient with 0 to 1, it's a rare exacerbation. Patient with frequent exacerbation is category of C or D, and patient with rare exacerbation A and B, clinical groups. How can we separate A from B and C from D? It's according to MMRC scale. For example, MMRC scale for patient A and C group from 0 to 1, cut less than 10. Patient with D and B group, so MMRC more than or equal to, cut more than or equal 10. That's why patient with B, it's patient with rare exacerbation, D frequent exacerbation, but MMRC and cut may be equal. That's why patient under the influence of our non-pharmacological treatment, the pharmacological treatment can be transferred from the D group to B group if we diminish of number of exacerbation. So we talked about parametric exacerbation. Diagnosis, we should rule out in case of COPD asthma, congenital heart disease, bronchiectasis, tuberculosis, bronchiolitis, and other disease which. But how can we influence through exacerbation? Firstly, it's vaccination, because respiratory virus and pneumonia can lead to, and now coronavirus disease can lead to bronchial asthma exacerbation. For stable COPD, patients should use annually influenza vaccination and anti-pneumococcus vaccination, and now vaccination against coronavirus disease. Goal for treatment of stable COPD at relief symptoms, improved exercise tolerance, improve health status, reduce symptoms, prevent disease progression, prevent the number of treat exacerbation, and reduce mortality, reduce risk. So management of COPD, including such review, diagnosis, initial assessment, initial management, and analyze response to therapy. So, but maybe so. What treatment not recommended for initial treatment of COPD? You should not use. We should avoid short-acting bronchodilators because it's a side effect, including the increased risk of cardiovascular disease. This you should know that patient more than 40 years old. For initial treatment, not recommended combination inhaler corticosteroids plus LABA, because corticosteroids increase the neutrophil count in the sputum. Neutrophil, you talk, is the main inflammatory cells in case of COPD. And in case of MMRC more than or equal to, cut ratio equal 10, monotherapy, long-acting bronchodilator is not recommended. We should start with combination LABA plus LAMA. So this less symptoms LAMA, but you can see it's not true. We should start LAMA plus LABA. If patient have eosinophils count more than 300 cells in 1 microliter, you can add triple therapy plus inhaled corticosteroids, but you should initial therapy should be LAMA plus LABA. Also, patient with B group with high symptoms start with LABA, not it's past recommendation, or LAMA, no. LABA plus LAMA. Now it's the last recommendation to 0.21. So I would like to stress once more, it's but you should start with criteria for treating exacerbation of COPD at home or hospital. How can we evaluate? Firstly, it's patient with severe dyspnea, Wuthering general condition, bad Wuthering patient activity, presence of cyanosis, peripheral edema, disturbances of consciousness, no care option at home, receive long-term oxygen therapy, rapid onset of exacerbation, comorbidity, including cardiovascular disease, insulin-dependent diabetes mellitus, diminished of saturation should, and also changes in chest X-ray, diminish of pH less than 7.33 and arterial PaO2 less than 7 kilopascal should be obviously hospitalized due to bronchial asthma exacerbation. Very important, patient with COPD should recommend physical activity. You can see this patient with failure of physical activity, inactivity during 4 years, it's 31 mortality. Patient with have got a good physical activity, 0 mortality. That's why stop smoking is the A grade level of recommendation. And now we have no time to discuss other things, but I would like to stress about respiratory failure, few words. Results for disturbance of gas exchange due to impairment of either oxygenation or elimination of carbon dioxide, or BOS. For clinical routine purposes, respiratory failure is usually defined by arterial oxygen tension less than 60 millimeter hydrogen, less than 8 kilopascal, or arterial carbon dioxide tension greater than 45 millimeter hydrogen, millimeter mercury. But therefore, the diagnosis for respiratory failure is a laboratory one. But the important point to emphasize is that this cutoff value are not rigid. They simply serve as a general guide in combination with the history of clinical assessment of the patient. There are 2 types of respiratory failure. Type 1, functional failure of the lung itself, primary results in arterial hypoxemia associated with normal or even reduced level of PI carbon dioxide as a consequence of compensatory augmented ventilation. It's so-called parenchymal respiratory failure, type 1. Type 2, hypercapnic respiratory failure caused by a mechanical disadvantage such as lung hyperinflation in COPD, central nervous system abnormalities of respiratory muscle dysfunction to lead to elevation, partial pressure in the blood carbon dioxide level, often is accompanied with hypoxia due to alveolar hyperventilation. So, respiratory failure, lung failure, and pump failure. Lung failure is due to gas exchange failure manifested by hypoxemia, and ventilatory failure manifested by hypercapnia. Pump failure of respiratory system. Respiratory failure can be divided acute, for example, in case of pneumonia, and chronic in case of COPD, and sometimes exacerbate it's such term acute and chronic. And the severity of respiratory failure based on the measure pressure of oxygen in the blood or saturation, using of pulse oximetry technique. Normal range more greater or equal 80 millimeter hydrogen millimeter mercury pressure of oxygen, or saturation equal or greater 95%. One grade of failure according to saturation from 90 to 94. For second stage, it's from 75 to 98, and third stage, less than 75. That's why it's crucial, because previously lung failure we can assessment due to the grade of dyspnea. Now it's not true. Only by saturation. When we met with patient with acute process, it's accompanied complicated but acute sometimes acute respiratory failure. We check, for example, make pulse oximetry, and patient breathes by the air. It's for example, you detect that diminished saturation, for example, 93%. It means first degree of acute respiratory failure. In case of patient with COPD, we check and diminish at the rest. Patient have got a 88% of saturation of oxygen. It means second degree of respiratory failure. It means patient should use a long-term oxygen therapy. Long-term oxygen therapy. For example, using of concentrate of oxygen, but it's very useful for treatments such category of patient with COPD, but I can use these devices. Oxygen concentrator, it's provide volume of oxygen approximately 5 liters per minutes, and it's such devices use patient during physical exertion, and you can see, for example, 10 minutes of ratio deaths if patient used long-term oxygen therapy. Comparing patients who have no use this long-term oxygen therapy. Long-term oxygen therapy, it's approximately 16 hours per day. 16 hours per day. This is very important since, and we should strictly recommend patients with COPD with second degree of respiratory failure use long-term oxygen therapy when saturation of oxygen less than 88% at rest and lower. So the time of lecture is over. If you would like to put me some question concerning this lecture, please write down the chat, and we discuss this topic during practical classes. Thank you for your attention, and goodbye.